In the final section of our lecture, now we will talk about puberty menorrhagia. In this, we will talk about the definition and causes, diagnosis and investigation of puberty menorrhagia, and also about the management of puberty menorrhagia. Puberty menorrhagia. Menorrhagia is excessive bleeding or excessive menstrual bleeding occurring between menarche and 19 years of age. So after menarche, if there is excessive blood loss until the age of 19, it is labeled as puberty menorrhagia. This is the normal uterine lining here, and then this is the uterus of someone with menorrhagia, very thick vaginal wall. So this is the thickened endometrial lining or vaginal walls, somebody with menorrhagia. Causes of puberty menorrhagia is dysfunctional uterine bleeding, 95% of the cases. And dysfunctional DUB. DUB is very, very common disorder. A lot of patients comes to see the gynecologist with dysfunctional uterine bleeding. So 95% of dysfunctional uterine bleeding is on an ovulatory cycle. In the beginning, from the beginning of menstrual cycle or from the age of menarche, for the first few years, usually the cycles are anovulatory. Ova is not forming. So these are the cycles with menorrhagia or heavy menstrual flow. So anovulatory cycles, unopposed estrogen as a result of anovulation. Unopposed estrogen can lead to endometrial hyperplasia, and this can lead to prolonged and heavy periods. So dysfunctional uterine bleeding. Then endocrine dysfunction can also lead to puberty menorrhagia, in which we have polycystic ovary syndrome, in which multiple cysts are formed in the ovary, and this polycystic ovarian syndrome is lead to anovulatory cycles. That's the cause for dysfunctional uterine bleeding in polycystic ovarian syndrome. Then we have hypo or hyperthyroidism leads to menorrhagia also. Then hematological factors is ITP, which is idiopathic thrombocytopenic purpura. In thrombocytopenia, the platelet levels are low. Platelets are the cells that help in the blood clotting. So in ITP, usually the bleeding is more. Then von Willebrand's disease, leukemia, all these can lead to menorrhagia. Then pelvic tumors can lead to menorrhagia, which are fibroid uterus, sarcoma, botryoides, and estrogen-producing ovarian tumor. These are all the different causes of menorrhagia. Then pregnancy complications like abortions can lead to menorrhagia. Diagnosis is history taking is very important. Thorough clinical examination that can rule out the cause one by one is important to find out the what's the cause of the menorrhagia, puberty menorrhagia. Then evaluation is specially indicated if the menstrual interval is less than 22 days or more than 44 days. Lasts longer than 1 week, or bleeding is too heavy, then anemia develop. If too heavy bleeding, the person might get anemia, which is low hemoglobin level, and they feel she will feel very weak and tired and no energy and lethargic. Investigations for puberty menorrhagia is according to clinical diagnosis. Whatever the clinical diagnosis, go for investigations according to those diagnoses. Hematological examination, blood tests are performed, bleeding time, clotting time, platelet count, thyroid profile, because hypothyroidism, hyperthyroidism all can lead to menorrhagia. Clotting profile, an imaging study of the pelvis by ultrasonography. If there is any fibroid or growth, it should be found out. Examination under anesthesia and uterine curettage, if there might be any abortion or things like that, to find out if to rule out endometrial hyperplasia, we need to do DNC or uterine curettage. Management protocol of puberty menorrhagia, rest assurance and hematinics are important. If there is anemia, heavy bleeding continues, admit the patient for further investigation in which hemoglobin is done, peripheral blood film, platelet count, clotting factors, ultrasonography, thyroid profile, blood transfusion if required. So if the patient is keep on having heavy blood loss, usually it may lead to shock, anemia, so hospital admission is sometimes required for blood transfusion and different investigations. The management again admit for investigations. We said for all these tests, for hemoglobin, blood testing, clotting factors, blood transfusion. If primary dysfunctional uterine bleeding is present, usually progestin therapy, medroxyprogesterone is given. If patient is responsive, continue. If patient is unresponsive, then conjugated estrogen is given every 6 to 8 hours. If responsive, replace therapy with combined oral pills. If unresponsive, then examination under anesthesia and DNC. So if primary dysfunctional uterine bleeding, we start first with medroxyprogesterone. If responsive, continue for 2 to 3 cycles. If not responsive, we start estrogen also. If responsive, go for oral combined contraceptive pills. If unresponsive, go for DNC and biopsy. If it's secondary to some disorders like thyroid, ITP, leukemia, von Willebrand disease, some anatomical disorders, usually treatment of the underlying cause can treat the dysfunctional uterine bleeding also. So hospital admission is sometimes required to treat the anemia associated with dysfunctional uterine bleeding and to further investigate the cause of the dysfunctional bleeding. So that was all about the puberty menorrhagia or dysfunctional uterine bleeding. Thank you for watching sqadia.com.